Good morning, everyone. Welcome to day 3 of EDIC 2026. My name is Raya Al-Mazroui. I'm consultant endocrinologist at Tawam Hospital and STMC at Al Ain, Abu Dhabi. And it gives me a great pleasure to have my colleague and friend, Dr. Yasser Al-Hassan, with us today. Dr. Yasser, can you give us a brief introduction about you?
Thank you very much, Dr. Raya, for hosting me, and thank you for the introduction. So my name is Yasser Al-Hassan. I'm a consultant endocrinologist at Cleveland Clinic, Abu Dhabi, and an honorary associate professor at the University of Birmingham in the UK. And it has been a pleasure, really, attending this conference and speaking at the conference.
Thank you so much, Dr. Yasser. So our topic today will be around adrenal insufficiency, which is your area of expertise as adrenal endocrinologist. So can you give us initially an idea about the common causes of adrenal insufficiency, and then light a shed on this area, what could be the common causes here?
For sure. I mean, perhaps just as a brief reminder as to what adrenal insufficiency actually means, this is a state of when the adrenal glands are not producing sufficient hormones. And us as endocrinologists, we always like to tease each other and say, so what's the most important hormone in the body? And the answer is very depending on what we mean by important. So if it's the hormone without which we will die quickly, then it's cortisol. But if we mean a hormone that's important for day-to-day metabolism survival, then we mean insulin. But if we mean the most important hormone for reproduction and maintain the human race, then we probably mean something else. But so cortisol that's produced from the adrenal glands, of course, is regarded as one of the most important hormones in the human body. And the adrenal glands normally produce a couple of hormones, most important of which is cortisol. So the causes of adrenal insufficiency can broadly be classed into 2 to 3 groups. The first group is primary adrenal insufficiency, when the problem is adrenal glands themselves. And the other group is the secondary adrenal insufficiency, when the problem is in the pituitary gland. And there is an analogy that I always explain to my patients, and I say, think about it as the lamp, light bulb, and the light switch on the wall. So the light being emitted, that's the hormone being produced by the gland. The light bulb produces the light, but the control is in the is from the switch on the wall. So the switch is the pituitary gland, the light bulb here is the adrenal gland, and the light being emitted from the bulb is the cortisol hormone. So as I said, we class adrenal insufficiency as primary and secondary. Primary, the problem is in the adrenal gland. Secondary, the problem is in the pituitary gland. But actually, the most common cause of adrenal insufficiency is exogenous exposure to glucocorticoids. And by that I mean, because now in 2026 you will struggle to name a specialty, any medical specialty, that does not use high-dose glucocorticoids as a treatment approach.
Absolutely.
So what happens when people are exposed to excessive glucocorticoids, that switches off the endogenous cortisol production, and we become reliant on those hormones that we receive from outside. This can sometimes be classed under secondary adrenal insufficiency, but some people like to class it separately and call it tertiary adrenal insufficiency. So this by far is the commonest cause of adrenal insufficiency at present.
Amazing. So can you let us know or tell us about why, what are the early symptoms that a clinician can recognize? Because sometimes we see that there is often a delay in the diagnosis.
Yeah, so absolutely. So this is a challenge. So the symptoms of adrenal insufficiency, particularly earlier symptoms, can be quite non-specific. Okay, so so fatigue, weakness. If you see me last night, I was fatigued and I felt weak after a long day. So symptoms can be quite non-specific, and that's a real challenge. Obviously, when the condition becomes more severe and prolonged, then people can develop symptoms such as collapse. These are the more serious symptoms, like collapse, symptoms associated with low blood sugar, like sweating, dizziness, and so on. And we should always in the history look out for history of recurrent syncope, recurrent dizziness. But as I said, those are quite late symptoms and supportive of very, very low cortisol levels. So ideally, we would like to pick some of the earlier symptoms, but the challenge is that those symptoms are quite non-specific.
And expect that area, for example, especially on those patients who are using high-dose steroids or are replaced. And we will come back later to this part, which will be included in the education part. However, to look for predictors that could put the patient at risk.
You're absolutely right, because those symptoms are quite common in the general population, like fatigue and weakness. And another important one that I should have mentioned is unexplained weight loss. So always keep an eye, for unexplained weight loss in a patient. Make sure you're not missing adrenal insufficiency, because this can have serious consequences. But you're absolutely right. I mean, rather than try and look for those non-specific symptoms in the population, a smarter and more efficient way is to at least we should be able to pick them on those at risk. As you say, people who are already on exogenous glucocorticoids, then looking for those symptoms became even more important, because they have, what we call a higher pretest probability for having adrenal insufficiency.
And just to be online with the talk that we had on hypophysitis, so many patients now on an immune checkpoint inhibitor, so they will have lots of things that leads to non-specific symptoms. So in such cases, maybe a regular screen as based on recommendation with AM cortisol and other hormones would lead to early detection of these cases.
Absolutely. So those symptoms are common in cancer patients in general.
Absolutely.
And then they are treated with immune checkpoint inhibitors, and there is a risk of adrenalitis and hypophysitis, and therefore again it's important to screen those patients during the course of their treatment.
Amazing. So can you tell us about the tests that can be used to detect and diagnose or confirm the diagnosis?
Yeah. So the simplest and perhaps the most efficient way of testing individual is to do a morning serum cortisol. So you do serum cortisol between 8 and 9 a.m. in the morning. So as you know, the cortisol has what we call circadian rhythmicity. So its cortisol is high in the blood in the morning. It starts rising from about 3 o'clock in the morning, peaks by about 6 to 8 a.m. and then gradually drops during the course of the day. So a morning cortisol combined with measurement of ACTH, which is the adrenocorticotropic hormone. That's the hormone that will determine whether it's primary or secondary. So that's the hormone that will tell you whether the problem is in the light switch or in the light bulb, as I say to my patients. So combined together, that's an efficient way for looking for adrenal insufficiency. If the result is inconclusive, then we do stimulation tests. And so by this I mean we bring the patients, they have a blood sample collected for cortisol, then they receive an intramuscular injection of a synthetic ACTH, and then we measure cortisols 30 minutes later and sometimes 60 minutes later as well. But increasingly we're relying more and more on morning cortisol, because as I said, the majority of our patients with adrenal insufficiency nowadays, or the commonest cause of adrenal insufficiency, is people on exogenous glucocorticoids. And for those, you have to be very careful how you interpret an ACTH stimulation test. There are lots of pitfalls, so we rely more and more on morning cortisol these days.
And is there any precautions or instruction do you give to your patients before they check their AM cortisol in terms of sleep or avoidance of certain medications?
Yeah. So absolutely. So the key point here is that we're measuring morning cortisol. But if individuals who are on an inverted sleep pattern, for example, if they are, if they're doctors, or if they work in the police or armed forces, or or paramedics, or whatever as a profession that involves them working overnight, then their sleep pattern will be inverted, because the cortisol rise is related to sleep, not related to the time of the day. And therefore, you would just have to time the morning cortisol measurement to their waking up.
Yep.
So if they go to bed 7 o'clock in the morning and wake up, say, at 1 o'clock in the afternoon, then that would be when you would do your supposedly morning cortisol. If an individual is on exogenous glucocorticoids and you want to have an idea as to what their own adrenal glands are making, then we would recommend that they do not take any glucocorticoids for 24 hours, at least 24 hours, depending on what formulation. So if it's hydrocortisone, which is the shortest acting oral glucocorticoid, then that's 24 hours. But if they are on higher doses of, say, or on a more potent glucocorticoids, then we would like to reduce the dose of those glucocorticoids first before we're able to test them, just to make sure that we can get a reliably interpretable result.
Excellent. Thank you so much for the elaboration in this part. So now let's move to the treatment part. So what are the replacement regimen for these patients?
So the biggest, generally speaking, in endocrinology, we have a missing hormone, and we try and we aim to replace it in the most physiological way possible. This can be challenging with the currently available formulations to replace cortisol with currently available glucocorticoid preparations. So that we like to use hydrocortisone. So I'll take you actually back to so earlier, the aim was we want to avoid complications, and those people were universally over-treated. So yes, we fixed the problem of people not coming to harm from too little cortisol, but the problem then became is they were over-treated, so they were getting the complications of excess cortisol. And for that reason, my preferred glucocorticoid to give to patients is hydrocortisone. That, as I said, that's the shortest acting oral glucocorticoid formulation. It's said because it's shorter acting, between doses, you do get a period when patients are not overexposed to glucocorticoids. Now, this is not necessarily 100% physiological, because what happens is the moment they take the hydrocortisone, the cortisol levels peak, and then they quickly drop, and then you take another, then they peak. This is not really physiological, but that's the best we have. The alternatives is to use the good old prednisolone, but the problem is the contrary, is that prednisolone is longer acting, and again, having that constant exposure to glucocorticoid is also undesirable. We try not to use things like dexamethasone, because these are even more potent, even longer acting. But the future look bright, because now we have newer modified release hydrocortisone preparations. So Plenadren came out from Europe about in 2018, and is now licensed in Europe, and and it's now licensed by the regulator in Europe, and it's licensed for patients with adrenal insufficiency in general. And the idea is here that it's a modified release preparations. Patients can take it once a day, and there is a regular release of hydrocortisone throughout the day, but it tails off over sort of more towards the evening. So it's less potent than things like prednisolone. We also now have Chronocort, or it's licensed in the US is the name of Fmodi, and this is now licensed specifically for congenital adrenal hyperplasia. And and we're now working with the Emirates drug agency or medicines agency. Sorry, I'm very sorry if I got the name wrong. To bring those medications here to UAE to make them available for our patients.
Amazing. And is there any difference in replacement regimen between primary and, would say, secondary or tertiary adrenal insufficiency?
Yeah, so that's a very good question. So in primary adrenal insufficiency, generally the degree of adrenal insufficiency is more severe compared to patients with secondary adrenal insufficiency. So usually with most causes of primary adrenal insufficiency, you get near total destruction of the adrenal glands. But also with primary adrenal insufficiency, you don't only lose cortisol, you lose cortisol and other hormones that are also important for maintenance of things like blood pressure, namely the hormone aldosterone. So that can also be lost with primary adrenal insufficiency. So those patients are more sick, they have more hormone deficiency, and they are higher risk of complications of adrenal insufficiency. So those tend to traditionally need higher glucocorticoid doses. So for example, if we're using hydrocortisone, I tend to use 20 to 25 milligrams per day in divided doses. And I should have said earlier that when we divide the dose, we try and mimic the circadian rhythm. So we give the bigger dose of hydrocortisone in the morning and the lower dose in the afternoon. Commonly, I see patients here receive the second dose in the evening. And I say, what time do you take it? They said bedtime. But I say, no, that's not physiological. You need the second dose. You take the first dose upon waking up. The second dose, I say, is 3 to 6 p.m. no later. Because even people without adrenal insufficiency, after 6 p.m. we would all have low cortisol in our blood, and that's just normal physiology. Going back to the question on the compared to primary adrenal insufficiency, in secondary adrenal insufficiency, typically those patients, they need less glucocorticoid replacement, and in theory at least they are at less risk of complications related to adrenal insufficiency, but it can definitely happen. Yeah. So this is not to reassure individuals, but that's just to say why we end up using less glucocorticoid doses in those patients. So if primary adrenal insufficiency, we used 20 to 25 milligrams per day. In secondary, I tend to use 15 milligrams per day. I try not to get to 20. So most of those patients, they are on 50 milligrams per day.
Amazing. So so the journey with patients during the clinic will not end up only with explaining the causes, how we diagnose it, and how we replace it, but also we need education about something that is very specific, I would say, in some conditions, including adrenal insufficiency, which is the sick day rules.
Yes.
So can you just elaborate on this part, and how do you explain the patient in the cases of emergency, what they have to do? So that's actually the most important part of the management of those patients, and in my view it's also the hardest. The reason it's not hardest is when we are talking to patients about events, about what to do at home. That's not easy. It's very easy when they are in my clinic and they're in my control environment, and I send them for a blood test, I look at the blood test, I prescribe. Very easy. That's easy. Absolutely.
But empowering the patient is very, very hard. And so what I say there is why. Sorry, I have to explain why education is important. The reason it's important is because people with normal adrenal function, when they are stressed, our human body will respond. So the hypothalamus and pituitary will signal the adrenal gland to make more hormone to cope with a stressful situation. And this stressful situation can be anything from emotional stress up to undergoing major surgery or, God forbid, road traffic accident, etc., etc. So we have to tell the patients, because they see me 2-3 times a year, but then they're living throughout their life on their own. So it's just about empowering them and teach them how to handle the day-to-day stresses in life. That's very important. So the way I say to them, we divide it into sick day rules number 1, sick day rules number 2. Sick day rules number 1 is minor illness. So I tell them that's the illness that would make you call work and phone off sick, okay? And bit of viral illness, fever, sore throat, etc. And I also, in that group, I've started including extreme psychological stress. Most importantly, bereavement. Okay, so I now include that in this category. So I tell them when that happens, double the hydrocortisone dose. And so for example, if they are on 20 milligrams per day in divided doses, they make it 40 milligrams per day in divided doses. And I say to them, maintain that for a few days until you feel back to normal. You don't want to overdo it either. Absolutely. Because then you're exposed to the complications of excess cortisol exposure. So I said them do this for 2-3 days. So that's sick day rules number 1. Sick day rules number 2 is that's the illness that makes you think about, do I need to go to hospital? Okay, so that's the more severe illness. That's when you've got you start vomiting, etc., diarrhea, vomiting. That's the more severe illness. And for that we say you have to have a standby hydrocortisone injection at home, and patients or their relatives or their household should be all trained to how to use that injection at home. So they have to use that injection and then phone the ambulance and come to hospital. Having this injection at home and being trained on how to use it is very, very important. So I tell to my patients, when I say to them, take the injection, and then they look at it and they're all scared that they're having self-injection. I say to them, look, think of it like your seat belt when you're driving. Hopefully you'll never need it, all our lives we drive putting the seatbelt on. But most of us don't need it, okay? Because the majority of people who drive and wear the seatbelt don't, alhamdulillah, they don't experience a road traffic accident. So I said to them, think of it the same way. Because, if an emergency happens, that might save you.
Yeah.
So those are the conversations that I have with my patients. Now, again, I mentioned it's very easy to just spell it out.
Yeah.
But ensuring engagement, revisiting this every clinic visit, testing, because telling them is something, what they perceived is something else. So maintain, so in education is a constant process. And it doesn't end there because, as I said, I see them 2-3 times a year. But in between that year, they're going to the dentist. They're having an endoscopy. They're having colonoscopy. They're having a minor procedure, removal of skin, removal of lipoma from the skin. They're having general anesthesia. Again, and when they're doing those procedures, they may not see an endocrinologist at that facility.
Absolutely.
So it's all down to us empowering them with information. That's what to do if you're having this procedure. And the information provided not only should be told, it should also be written, in my view. It should be written in an accessible language. So building that network around the patient is, in my view, the biggest challenge in managing patients with adrenal insufficiency.
Actually, thank you for elaborating on this extensively, because I think this is a part that maybe in our daily clinic we are not emphasizing it. Myself, I do the same. I try to emphasize this point in each clinic visit.
Yes.
Because patients also, when they are long term, they forget about it.
Absolutely.
So it's important to remind them in each visit.
Yes.
So do you support them with anything else, like, for example, steroid card or
Yes.
a video that illustrate how to inject?
Yeah, so absolutely. So the written information that they receive includes a patient information leaflet that we have produced and translated in Arabic, and it tells them what's adrenal insufficiency, how it's treated, what symptoms to look for, and it tells them about sick day rules number 1, sick day rules number 2. So they have that, and I offer a repeat copy every single clinic visit. I said, do you still have it? And then if they misplaced it or wear and tear, then I give them a new one. The steroid emergency card is an absolutely crucial point. So again, that's part of building the safety net around the patient. So this is a card that the patient with adrenal insufficiency should hold, that in, God forbid, in case of an emergency or a crisis, the paramedic comes, or if the patient goes to the emergency department, the patient is too ill to communicate what's wrong with them, then they can either hand the card, or paramedics are trained, if they find a collapsed patient, to look at their pockets, to look for clues as to what has been going on. So if they find that steroid emergency card, that patient is potentially saved. So it's very important point that you raised, which is video. So now in the sort of in the tech era that we live in, even most of my patients, they have access to a smartphone. They can access sort of YouTube videos on their phone. And therefore, we should also make available to them material that they can refer back to as a refresher whenever needed. So that's, again, building that safety network around, or the steroid safety network around the patient is a challenge, but we have to get it right. We have to keep working on it.
Absolutely. So coming to the last part of the talk, so how long these patients will be following with us as endocrinologists?
Yeah.
When will you decide to discharge them, and if they can be discharged, and how do you handle this to their primary care physician?
Yeah. So I don't discharge my patients with confirmed primary adrenal insufficiency or confirmed adrenal insufficiency. I don't discharge them. So this is a chronic medical condition. They are, so the endocrinologist is the person who knows about their condition the most. Now, and I tailor the follow-up to the patient. So some of my adrenal insufficiency patients, I see them once a year. Some I see them 4 times a year. And it also depends on what the cause is, the cause of adrenal insufficiency is. For example, if the cause is, say, congenital adrenal hyperplasia, then women with congenital adrenal hyperplasia, they might have fertility issues, so usually there are also some other issues that that require more frequent monitoring. But I don't discharge my patients. I see them, I revisit the sick day rules every time. I make sure that they have the hydrocortisone injection at home and that it hasn't expired, and I refill it if it has. And I try and be their advocate. I try and orchestrate their, even other managements. For example, if they are having orthopedic surgery, then I give them to whom it may concern letter, because where I work, we don't have an orthopedic department, and therefore I give them, so they won't have it where I work, they'll have it elsewhere. In that place, they may not have endocrinologist, so I give them a letter so that they hand to the department there, and that letter will say, this patient has adrenal insufficiency, they need steroids cover around the time of surgery. So for all those reasons, because they will need our constant support, I don't tend to discharge those patients at all.
Excellent. Thank you so much, Dr. Yasser. It was really great pleasure to have you, and you enrich us a lot and hopefully enrich the audience as well.
It's a pleasure. Thank you very much.
Hopefully to see you again, inshallah. Thank you so much.
Thank you very much.